Good morning.
Hi, Sarah. I just wanted to make sure that my mic was working because the last time I was in a meeting that had to have IT like do something with my computer settings. So you can hear me, I take it.
I can hear you. I can see you. Do you want to run your own slides or do you want me to?
I don't care either way, but I just show me how I would do it. I guess that is if I can do it.
I just made you a co-host. So
Okay.
then you should be able to share your screen and like pop up your own and just kind of roll with it, if that makes sense. I know like in the reformatting, there were a few issues. I think your slides are okay, but a few of them like didn't transfer over seamlessly, if that makes sense.
Let me pull that up real quick. Let me go into Sent. I'll probably find it easiest there. I did this on my phone, which is weird, I know, but you know.
No, not at all.
So then when I was like, you were like, oh, it'd be better in a PowerPoint. I was like, I wonder if I know how to make something change to PowerPoint from Google Slides on my phone. I was like, So let me take a minute and just go through my Sent things because I think that'll be my easiest way to pull this up and just make sure it looks. I think I sent you this on Tuesday.
Hello. Oh,
Good morning.
hi. Hey, Sarah, do you mind if we show our slides? If I show my slides?
I just made you co-host, so you should be all set
Oh, that's
to
great.
share your screen.
Okay, that's good because I don't understand why in the transfer why the slides got all kind of jumbled up.
Yeah, I think because we were using like here within the state, we have to use PowerPoint. So because when we transfer stuff over from like the Google slides, it doesn't always copy.
I know, but I made it through PowerPoint with that.
Yeah, but it was formatted in a different size once they reformatted it.
Yeah, I have my.
Can I try sharing my screen real quick?
Absolutely, yeah.
So do I just hit the green button that says share screen?
Yep.
Okay, and then I go like this and hit share.
Oh, you're doing it.
You see what I'm seeing? All right.
Yes, you did a great job.
All right. Great. So that's easy.
All right, and we'd like to thank you for joining our September meeting of the Innovation and Quality Advisory Council. The slide deck will be shared with you all at the end of the meeting. We ask that you remain on mute unless you're joining in with a discussion portion of our conversation. And feel free to use the chat or raise your hand if you'd like to add any additional comment. So without further ado, I turn it over to Paul to get things going.
Thank you, Sarah, and welcome everybody. Glad to see you all here today. Again, we're going to continue our discussion of person-centeredness today with some specific approaches that certain organizations have taken. In order to get us started, I'm going to turn this over to Lauren.
Great. Can you put the slides up, Sarah? Yep. All right. Great. Okay, next slide. So, I'd just like to take a minute. I love this topic, actually. I'd like to take a minute to put today's discussion in context. A lot of the information that we are paying attention to these days comes from the National Academy's report, which was released in 2022, the National Imperative to Improve Nursing Home Quality, which recall it's an almost 600-page document that thoroughly describes some of the challenges that facilities face in meeting the needs of their residents. And just to remind you of some of the conclusions that the committee found. These are just some quotes from the first chapter, actually. The way the U.S. finances, delivers, and regulates care in the nursing home settings, ineffective, inefficient, fragmented, and unsustainable, and immediate change is necessary. And then there's some examples of how the nursing home sector has suffered for many decades from underinvestment, such as low salaries, inadequate support for staff, quality measurements have ignored the resident and family voices, and sometimes lack of transparency regarding ownership. Next slide. So, and these are the 7 recommendations described by the NASEM report. I'm not going to read through them, but right now, the highlighted words are kind of the themes that move through the entire report. The need to deliver person-centered, equitable care, the importance of a workforce. We need a robust financing system, quality assurance, quality measurement, and continuous quality improvement, as well as health information technology. Next slide. So today, our goal is, as Paul mentioned, is to explore goal number 1 a bit. Try to get all of us thinking about this question: what does person-centered care mean? What does it look like? I think it's a term that's used frequently in healthcare today, and I think it might mean different things depending on what type of care is being delivered and where that care is being delivered. So again, I'd just like to maybe just invite us all to dig in a bit. What is person-centered care in a residential care facility? Can we define it? Do we know it when we see it? And certainly, can we measure it? So with that, I'm going to turn it over to Angie for a description of what her work is like over at Cedars. Thank you.
Thank you very much. I'm going to share my screen. Just bear with me for a second. Oh, good.
And Angie, I'm not sure that you've joined our prior meetings, so maybe you want to just introduce yourself briefly.
Okay, thank you, Paul. My name is Angie Hunt, and I am the Chief Innovation Officer at the Cedars, located in Portland, Maine. Okay, so good morning, everybody. And on behalf of the Cedars, I really want to thank you for the opportunity to speak with you today. And today you're going to hear a personal story, a story about the Cedars and how we used Age-Friendly Health Systems Initiative to assist us in improving person-centered care, improving our clinical outcomes, and this includes the care planning process. Before I begin my story, I really wanted to communicate one piece of important information about the Cedars. In March of 2021, during the pandemic, we opened up the Sam L. Cohen households. We had studied several person-centered models of care and implemented that. We decided on the household model. The household model is much like the name implies, and it brings with it both design and operational elements focused on person-centered care and home for the residents. And when you experience this model of care, you really realize that it goes beyond this innovative design. Residents are served by a staff dedicated to the household and are cross-trained. They're blended workers in a variety of functions such as activities, housekeeping, homemaking. There are 20 residents living in a household. They all have private rooms and private baths. There's a kitchen with 24/7 access, a living room, a formal dining room, den and sunroom, just like you have at home. The same person providing your personal care can also read you a story, maybe make a craft with you, make your bed, clean your bathroom, or help serve a meal. Staff in the household really strive to create community through the building of relationships. Relationships are really important in the household model, and they're important with staff to staff as well as staff to resident. And the adoption of a philosophy of person-centered care that really seeks to develop individuality living on the residents' own terms and schedules, really instead of shaping their lives around a set schedule put forth by the Cedars community. So today we're addressing care planning, and the care planning process is essential in capturing and communicating the residents' individual story and what matters to them. But it's equally important to have the systems and the processes to communicate this important information to all direct care staff and making sure that the resident wishes are honored. So there needs to be follow through and accountability also. In February of 2022, the Cedars joined the Age-Friendly Health Initiative. This is the national initiative of the John A. Hartford Foundation and the Institute for Healthcare Improvement, IHI, in partnership with the American Hospital Association and the Catholic Health Association of the United States. The goal of Age-Friendly Health System Initiative was to develop the 4Ms framework into clinical practice by the adoption of 4 essential elements, which implemented successively will improve quality of healthcare to the residents that we serve. And briefly, the 4M framework consists of what matters, knowing and aligning the clinical care of each resident's specific healthcare outcome goals and care preferences, medications using age-friendly medications that don't interfere with what matters, mobility or mentation, preventing, identifying, and treating dementia, depression, and delirium, all very common diagnoses of chronic conditions that we see day to day in long-term care communities. Mobility, ensuring that our residents can move around safely every day to maintain their function and really do what matters. The 4Ms are really intended to make complex care of our residents more manageable. They identify core issues that should drive care and decision-making for older adults. The intent is really to incorporate the 4Ms into your existing care and care plan, and the integration of this is achieved primarily through redeploying existing resources. With a commitment to improve the health and healthcare of older adults, the decision of the staff to implement the 4Ms was an easy decision at the Cedars. I didn't have to twist anybody's arm about this. And as we moved through the process of developing our action plan for each 4M, it really became obvious to our team that we were already providing a lot of this care that's aligned with the 4Ms for many of our residents. But we also came to the conclusion that we weren't doing it as consistently as we should. And our overall goal in the implementation for the 4Ms really was to provide 4M care equitably to all our 55 long-term care residents by February of 2023. So there really are 2 major drivers, key drivers of age-friendly care. The first is assess, knowing about the 4Ms for each one of your residents in your care. And the second driver is act upon, and that's incorporating the 4Ms into care delivery, documenting that in the care plan. Both key drivers are supported by documentation in the medical record and communication across disciplines and different settings. We developed 3 multidisciplinary teams at the Cedars to undertake the implementation of the 4M care. 2 teams were located in 2 of our long-term care neighborhoods, and 1 team was located in our long-term care household. Each team had a dedicated staff to it, which included the nurse manager of the neighborhood of the household, a care coordinator, which was a social worker, an OT or a PT was part of that team, and a life enrichment or therapeutic recreation specialist. The nurse manager served as a primary link to the direct care staff, and then that person met with staff through huddles, shift report, and learning circles to communicate information. The entire program was spearheaded by the director of nursing, the assistant director of nursing, excuse me. And once everybody on the teams were educated about this, we were ready to jump into action. The team identified and implemented several evidence-based best practices in the areas of what matters, medication, mentation, and mobility. And our action plan incorporated 4 things: who's assessing each one of those 4Ms, what were the tools we were using to do that, how each 4M, how did we act upon it, and where each 4M is documented, and how could the staff access this information. This is what our What Matters action plan. We did action plans for every 4M. I'm just showing you what matters. The aim is to know and align care with each resident's specific outcome goals and care preferences, including all stages of health and across all settings. So as you can see in the discipline column, providing direct care to the resident is the responsibility to capture what matters to the resident, especially in each discipline's area of expertise. There are also several tools and standardized tests, best practices that long-term care providers can use to capture what matters to the resident. This is specific to the Cedars. Each community might have a little different look at this. And each discipline obviously does an evaluation of the resident, inclusive of what matters. So I'm a physical therapist by trade. If I do a physical therapy eval and the resident talks about, a person talks about, let's say it's a short stay rehab, they're going home and they have a pet, and it's important for them to be able to have the balance to get down to feed their pet. That should be a goal that I would incorporate as a very person-centric goal and care plan for. And our medical providers also provide clinical care based on what matters to the resident. And IDT meetings, life stories, life narratives, advanced directives, the pulse are all tools that capture what matters to the resident and should be utilized and care planned for. Our action team included the frequency at which this information is gathered. So you start gathering information before the resident even comes to you on what matters to them. It could be through change of condition. It could be through quarterly IDTs. You're kind of always capturing this information. The action section depicts on how what matters is acted upon. Where is this information communicated? And we have daily stand-ups. We have daily huddles in each of our neighborhoods and households. We do learning circles in the households and in the neighborhoods. Shift report, IDT meetings, the iCare plan, and then we don't do this anymore, which I was disappointed to hear, but we had a caregiver pocket care plan that really had some really good information on it for our direct care staff. And lastly, where is this information documented? Written documentation really on what matters is in the resident's electronic record, but it's really in the iCare plan. But what matters is also addressed on our interdisciplinary. We have an interdisciplinary form, and what matters is on that form. With the adoption of the 4Ms, the CEDARS team decided really to utilize or introduce the concept of the 4M and age-friendly initiative through the IDT meetings. That's how we would start this off. And technically, if we use the quarterly IDT meetings, we could really have all 55 of our long-term care residents in the program by 3 months. But we decided to do it through a 9-month goal. And today I'm happy to report that we have reached that goal. And with every quarterly IDT meeting, we review all of the 4Ms. We also have altered our IDT documentation to reflect our new approach and to incorporate the 4Ms. The CEDARS team decided to add 4 questions regarding what matters to the resident. And these 4 questions are addressed at each IDT meeting, and they're formally updated and documented on that IDT form. And the 4 questions we ask are right there. What matters to you? Are your goals, routines, and preferences being followed while you're at the CEDARS? Do you know and understand the medications you're taking? And what are your mobility goals and preferences? Those are our core questions, okay? Depending on the feedback, our follow through on our issues or concerns if somebody answers those questions. If it's a medical concern, we usually have the nurse follow up on that. If it's a non-medical issue, we usually have the care coordinator address on that. And the IDT meeting is really a great time to update the care plan and adjust for what matters to the resident. Sometimes I think we do a great job at collecting all this information and providing a detailed person-centered care plan, but it's equally important that you have to execute that, communicate and execute that care plan, and have the processes and systems established to do that successfully. And you need to really track it too. So along with establishing our action plan for all the 4Ms, we also developed a short-term goal for each of the 4Ms. And our short-term goal for what matters was to have our life enrichment department responsible for monitoring and completing each resident's life story or life narrative for all of our long-term care residents. Preferably, the life story would be completed prior to a resident moving into the CEDARS. But that would help so the staff could properly welcome the resident and know from day one what some of their routines and what some of their wishes would be. Participating in the age-friendly initiative allowed us to refocus on what was important to us as an organization, which was quality care and person-centric care. And and for us, the person-centered care started really with knowing the resident and developing that positive relationship. So needless to say, we believe that capturing the resident's life story is essential for providing good person-centered care, quality care, and for meaningful life for that resident. And the life story is definitely a foundational practice that we do at the Cedars. The life story is widely recognized as one of the most important components in the effective treatment and care of residents, and is especially noted in the care of people living with dementia. You really need to have those life stories to provide good quality care. The life story will also allow you to know the resident as an individual, know what matters to them. It's a significant tool in developing personalized care, knowing their routines and preferences, honoring them, help engage residents in meaningful life, also conversations, developing, talking to them about memories from the past, building social connections and relationships. It's a great blueprint for helping somebody have a really purposeful, meaningful life at your organization. And at the Cedars, we also capture music histories, likes and preferences, as music is a really powerful tool to promote healing, engagement, and joy. And I cannot stress the importance and benefits of adopting this practice of capturing these life stories. Also, the importance of creating the processes and systems where all staff can easily access this information to provide better care. Capturing life stories can surely make the care plan process much easier and more in tune to what matters in meaningful life for that resident. So really to sum it up and to provide the person-centered care, the team, the Cedars team, this is what we did. We agreed to adopt the 4Ms. We agreed to introduce the resident and family members to the program through IDT meetings. We captured all the life stories on our residents to utilize this in the care planning process. We selected 4 questions on what matters to the resident, highlighting the 4Ms, and we reviewed the care plan with the resident and the family, obviously at the IDT meetings. And besides documenting the information in the medical record or the IDT form and updating that care plan, we consciously try to talk about what matters in the life story information in huddles where the CNAs are involved in these huddles, and learning and community circles and shift report. And lastly, we also tried, I'm going to show you later in the presentation, to track and monitor some of the outcomes that we have, because it's important to continue to follow up and make sure you're successful. So I gave you a little example of a case study. This was a 94-year-old woman. She lived in the Samuel Cohen households for 1.5 years. She had a dementia diagnosis, and she had several chronic diseases. She also had some behavioral concerns. She could be aggressive at times, and she yelled a lot, unfortunately. And recently she had, when we did this case study, which was some time ago, she had a fall, but she didn't have an injury. And then we obviously did life stories and music histories on her. So we had great information on that. Now this isn't the age friendly, but people, we have people that live with us. So meaningful life is really important, and you want to be person-centric. And I just wanted to give you a list of things that we did with her that were very person-centric to her history. Like, her father was a minister, and she lived on a farm, and she played the piano in church, And she, even with her moderate dementia, could play the piano. We got her a keyboard. We gave her music books. She loved her family, a book of her family. We did lots of things. And we also put her in some formal programs like Opening Minds Through Art, which is an intergenerational art program. So we tried to do a lot of stuff. We have Memory Lane TV. I think 60 of our nursing homes now have that through our coalition. That have Memory Lane TV, but there's a lot of Maine history in there. They have the Freiburg Fair, and her eyes light up when she sees all those animals because she lived on a farm. So, really being person-centric with the life of that person, their day-to-day life. We removed the medications. There wasn't much with her with medications, but we review those with her and the family. The other thing is looking at mentation. We have all these great tools. We do the BIMS. We happen to use the Allen test because it goes well with GEMS and TIPA Snow positive approach to care. And this person was an amber to emerald gem in the gem state. So, incorporating that. So see, we're doing a lot of great things in all of our care communities that support the 4 M's. And then obviously with the PHQ-9, which is part of the MDS. Because this person fell, there was an SBAR put in and they had a PT screen. They did a tug on that person. So following through with that. And this is addressing the 4 M's in the care plan. So this is just a little snapshot. This is not the whole care plan, obviously. But, look at what matters for us. It was important having that help, that life story so that we know what her routines and preferences were, having the post in. This was really important. This resident really wanted to make sure she was involved in decision-making along with her resident representative. Medications, there wasn't much to say. I think we had no changes. With dementia, we did a lot. We, with our dementia diagnosis, as we did do the Allen's test, we had an OT come in. We care planned for the positive approach to care strategies with her. So we had specific strategies put in the care plan based on her level of dementia or a cognitive level. And then depression, though she didn't have depression, we did look at socialization because she loved people and she loved her family. So how did we address that? And then her mobility. Now her mobility during the ITT, she should have had therapy. She should have PT. She's at high risk for falling. But her and her family decided they didn't want PT. We ironed the case for having PT, but they decided not to. And we put her on a fall prevention program. She wanted to really walk by herself, but we had distance supervision and frequent rounding on her. And that's how we addressed her care plan. So that's just an example of how you would adopt some of these age-friendly strategies.
Angie, this is absolutely wonderful, and I hate to cut you off, but we'd like to allow time for questions and discussions. Can you move toward a wrap up?
Yeah, I surely can. The other thing, use your CASPA report. Do that because sometimes when people trigger, and I just wanted to show you that the Cedars in March of 21 was at 28% antipsychotic use, which is horrible. But when we started age-friendly on March the 22, we started in February, and we did all of this stuff with dementia training, and that just age-friendly can help your clinical outcomes. And this was just a tool that we use, so you see it. And then I want to say, don't forget to use expressive arts programs because they're just as good as the clinical medicine part. Okay, and that's it. Thank you.
That's amazing. Sarah, can you take the slides down for a minute?
Yeah, I can do that. Sorry.
Thank you. So, any thoughts, questions, comments?
Yeah, I just want to say that was wonderful. I, feel like you guys have ticked so many boxes and I'm super impressed with everything you did. And I can't agree more with the overall message. I We'll also talk about our very tiny piece of addressing some life stories, and I do agree with you, trying to have this be done prior to move-in seems like the most impactful, and I was curious how you managed to do that. Did you, meet with the people ahead of time, do this over the phone, or what was your process for sort of trying to get life stories ahead of moving in?
So, great question. So basically, if we know somebody's going to move in at the Cedars, okay, like in our assisted living and our dementia program, we actually have the staff go to their home and see them in their home and look at their bedroom and try to provide a commonality so that that transition is not as difficult. Now, if they're in short stay rehab and they're moving to long-term care, we try to get that life story because they're in the building. And we usually go through the family if the resident cannot provide that information. And even music histories, we're trying to capture. We don't do it on everybody. We're not as good as the life story, but music histories are really important to capture because it's really good to do music and memory for the residents. Everybody should have that program as far as I'm concerned. And if they don't get it right away, we try to get it as soon as possible. But it's so much better when the staff know the person before they actually come in. It's just so much more welcoming.
Angie, it's Maureen. That's fabulous. I've talked to Peter Baker a little bit. Have you been involved with his age-friendly community group?
Yes, I did present to them one time.
Oh, it's great to hear it in action. I've heard Peter's stuff and it just sounds so cool. So now to hear somebody actually put it in action is great. Just to let people know that Peter will be presenting on the age-friendly communities, which is where the 4 M's, I believe, comes from, right, Angie? At the Maine Healthcare Fall Conference. So another great learning opportunity more about this program. So thanks, Angie. It's great stuff.
Yeah, and it's not, I think that was the easiest program to sell to the staff. And the reason why is because we didn't sell it as a new program. We actually told them that, they actually took each action plan, like on mentation, that they made goals for each one. And basically, you're already doing a lot of this care. It's just that we really weren't doing it consistently. Like we did life stories, but did we make sure we had them on every single resident? No. And I think really the capturing of the information is, for me, the easy thing. The hard thing, I think, is really communicating that information to your staff and having the processes that they can access this information and they act upon it. And how do you know if they're acting upon it? So those are, to me, the key things to really being successful.
Yeah, I have a question. Great presentation. Thank you very much. I am curious about the communication links. For example, I know you asked what matters, or is that separate, or is that the same thing as the life story? And how exactly does the life story information get translated into the care plan in terms of actions? Great.
So first of all, they're separate things. Okay. So when we do an IDT meeting, okay, the care coordinator, the social worker who runs the meeting knows to ask every time those 4 questions that I showed you. Okay. And then that is documented in the medical record. Okay. The answers to those. Okay. The life story is something that is done completely separate from the IDT. And during that IDT, if they get new information, that new information is translated on the care plan. Okay, so they're definitely separate things, separate entities.
That was sort of my question too. I think, care plans are mysterious things to physicians and to maybe people who aren't involved. I think the care plans are typically written by nurses, and as you insert all these elements, how do you ensure that that people read the care plan and act on the care plan, the whole team, for example?
Okay, I'm going to be perfectly honest with you. A CNA does not read the care plan that's in the medical record.
Yeah.
I'm just gonna be upfront with you. That doesn't happen. I wish it did, and that's, I think, one of the challenges. Now, we did do a pocket care plan, which was a Cardex system that had all the important things to the resident and some resident information, and that worked really well. The other way we do is we really meet with the CNAs, okay, in huddles. And that information gets transferred in huddles. But could we do this better? To me, it would, I think that process could be improved even obviously for us too.
Right.
And that is one of the challenges. And I think when you look at your going forward moving coalition and you do care planning, those are some of the challenges you're going to have to think about
Right.
and try to help with.
Right. You know what? We're going to have to move on, but we have a couple questions. Ruta asked a question in the chat. I'm curious what role, if any, CNAs play in your care plan meetings. Maybe some of that is redundant here. They participate in the meetings, but do they? How does that look like in your?
We would love the CNAs to go to the meetings, but that doesn't happen. It might happen if we ask them specifically on a certain resident. I think with our staffing issues and concerns, I think that's something that doesn't always get. But what we do, which works really well, is we really have these huddles, and the CNAs are in those huddles. So when we talk about information, the residents, the CNAs can give you tons of information, and we talk about issues or concerns in the household or the neighborhood. Those definitely the staff participates in them.
Right.
From the bottom line.
There's one more question. Have you seen an impact in staff retention or ability to hire? Any workforce stats to share?
I think it's great because we have kind of a traditional looking skilled nursing facility, and then we have this household model. I would tell you that people in the household model love it. They love working there. They love the atmosphere. And I feel that it's a really good recruitment and retention program.
Great. Okay, perfect. That was wonderful, Angie. Thank you so much.
You're welcome.
And I think it's time to turn it over to Deirdre, Dr. Heersink from Maine General Rehab and Long-Term Care, Gray Birch. Thank you for being here.
Thank you for inviting me. I'll try to share my screen. Let's see here. And this is a good dovetail because let's see if this is going, kind of did a really similar small piece of what you guys were working on. I do think Age Friendly is great. And I went to an IHI conference in the fall about a year or so ago, and I was very excited to do it, but you really need a lot of people on the bench to kind of help actualize it. So we had this small carve out piece where we started with the life story piece of this, because I think when I look at the 4Ms, I think looking at what matters most helps really keep our focus on the resident, and we can organize the rest of our care if we have a sense of that. So I'll tell you a little bit about our pilot. Hopefully you had a chance to maybe watch that BBC 8-minute segment because they did a good job summarizing our process. And I'll just give you a tiny context. I'll go through this part pretty quick, but from my perspective in this role, it's obviously been a big learning curve. I've been doing, this kind of medicine for about 5 or so years. And certainly when I worked as a hospitalist, I would be sending people to skilled or to long-term care. But when you're kind of in the culture to full time, you realize, ultimately just all of the complexity that people are, in a situation, oftentimes, moving to a place they've never seen before without really having a lot of opportunity, very different than, for example, when I dropped my daughter off at college last fall, where, we spent a long time visiting places, finding fit, packing her bags, thinking about what would, seem like, how can you connect with a community that you want to be a part of versus, when our folks are sent after some, unexpected medical emergency that lands them in a hospital stay, and then they end up in skilled rehab. And oftentimes some of our folks in a long-term care, this is the path that they originate from, is finding that their care needs exceed their ability to get the care at home. You're all familiar with this, of course, but it's, I think the context is difficult. So, you know, you've just described this perfectly well. The piece of our puzzle that we were sort of looking at is focusing first on the what matters piece, and then gonna try to keep working through the rest of those pieces. But we couldn't take all the pieces at one time with the team available. This really was just from my perspective through COVID and everything in the last couple of years, this sense of trying to maintain sort of three pieces of focus. One is, where are we? Two is, where do we want to be? And then the how, and how do we get there for the middle steps? So obviously the context, really everybody knows clearly, like COVID just stopped the world turning. Nobody was coming in, nobody was coming out. And I think the challenges that faced for residents and staff were huge. We're all familiar with them, but the isolation, the lack of volunteers, the strain on everyone involved in the care during this time, obviously doing things we didn't think we'd be doing, like guiding people through saying their final goodbyes to their loved ones over the phone. None of our staff expected that or was trained for that. And I think clearly the challenge of going through that and coming out the other side is still with us, you know, even though the state of emergency is over and a lot of the community, you know, rules have changed, we continue to have to operate with this as a part of our reality, you know, obviously not to the same intensity, but it's still a very challenging workplace at times. And I would say the things we're looking for out of our staff that we know makes things go well is this sense of strong connection. But I will say, when you really develop strong connection with people, then when you have large amounts of losses, the kind of emotional toll of that is very significant. And I think part of our staffing challenges, I think, are not only is the work hard and the conditions, you know, challenging, but I also think the losses and the relationships have a huge toll as well, of course. So, you know, for us, when we had our outbreak, one of the things we certainly recognized was we were learning certain things about people in their obituaries, which is not the time that you really want to be learning new things about people. This was a resident here for a long time, and there was a newspaper article about her obituary, and personally, I've never seen that line of, I finally have the smoking hot body I always wanted. I've been cremated. And my ashes will be spread in the water in various locations. I'll be swimming all over the world. So I certainly, you know, amongst many other things I learned about a lot of people, felt like this is just not the time to be learning more things. So in this context of basic significant demoralization, we had a stage in our sort of post-outbreak, you know, everyone drew close together, but then totally just tuckered out, really. And we had 100% travelers for our nurses for a pretty long time. And that's very difficult because you're having, you know, new staff meeting residents on this rotating basis. And that's a lot for all parties. There was a program that was through Not Impossible Labs that had a award ceremony, and they chose this memory well as something to do a little mini documentary about their program. And if anyone wants to see, you can see the Not Impossible Labs memory well. It just shows the initial video that I had seen that thought, maybe this is something we could potentially do with our residents that would help engage our staff and help make quicker connections really between our traveler staff and our residents here. Obviously, in this region, it's a very tight-knit place, and I think the time and relationship, it's really hard to quantify the value of it, but you know, I think there is you know, I don't know who's going to do these studies on what are the health benefits of connection, but I do know I recently saw that Blue Zone Netflix documentary on Live to 100, and certainly across all of those places, if anyone has not seen that documentary, connection and community are a common thread for all people, you know, kind of having a quality longevity. So this was our idea, was to try to see if we did some life stories where we partnered with MemoryWell, if it would increase some of our volunteer engagement and get increased resident satisfaction and the staff satisfaction. So we partnered with the Maine Health Access Foundation. They gave us a grant to do this program. And again, I kind of thought it'd be pretty easy, but of course, whenever you are doing something, there's a lot of layers like legal and HIPAA and all these things. So we, worked with our legal department to work out a link, and that is an easy step. It's just, you can have it on a tablet or a phone, and that gets reviewed and signed by either the resident or their POA. And then we had volunteers partially to extend the reach of our grant, because we could do twice as much work for half the money, basically. So we had help volunteers through the hospital that trained to come and do these life stories, where they would sit with residents for 40 minutes or so, and they had some questions to guide their conversation, but a lot of it just takes life as you get going. And they would record this on a Zoom link that would be automatically sent to MemoryWell. Then a professional writer would write this up, and then the draft of this was read by the CNA staff to the resident, that then they could do some edits if there was something missing or somebody's name wasn't correct, these kinds of things. And then when they get the final copy, they laminated it and would put it in their room. This hopefully is something that we could really develop into increased activities for resident experience. I would say in some instances we've been able to do that, but that would be, kind of like something to kind of grow between. I do think your options of utilizing parts of these life stories within the care plan would be optimal. So I think that's a good thing to do. There is some options through MemoryWell where you can use their site and have it on a tablet, and you can look at the stories there. It's actually very visually pleasing, very easy, but for our IT, they were worried about security, so that was not something we were able to actualize. But there are certainly a lot of features that are possible that we just went very simple and had a laminated version of the story hung in the resident's room, partially because that's a place that it actually gets. We also had a binder with these in them as well, but I would say there's not that often that CNAs are sitting around looking at a binder. This is just a couple sample questions. We had others, we sort of modified them over time, but this is an example of a life story, and certainly the pictures always add another point of just recognition of the many chapters that have come before. We worked with a Colby student during his Jan plan to, part of his was he helped with this completing some life stories with our pilot. He tried life stories in different locations. He did one in the hospital for somebody before them coming to long-term care. He did one at our sister facility that is a memory care facility, and then did some on a assisted living and here. So just sort of trying different settings and seeing how it went. And I think from his experience, it was a very, honestly, a great thing for any medical student or person thinking they might want to go into medicine to do, because a lot of what you do is obviously talking with residents or patients, and that is kind of a learning curve to get good at that. I have a very long story that I'll skip, but about his one individual patient, that resident that he had that really, he had lost a spouse, had an acute delirium, but it was interpreted as if he had advanced dementia, and he had been held in an ER in an outside hospital, sent to a 24/7 nursing home memory care. And as he was there, as people began talking with him, it was sort of like the wheels started clicking as his delirium cleared. And by the time the story went forward, even after a 3-week hospitalization with really no change in his management, his delirium completely cleared, and he ended up being able to be discharged to a independent apartment. So bottom line is this, having some toeholds to connect with people helps you gain traction. This is where we try to share some of these stories, is we have a little huddle area where we go through a little bit, just some stories that are new, some questions about some of our residents that people may not know, but to sort of quiz themselves to see if there's interesting things. These are a couple samples of some questions. The one that really got me, I couldn't answer the number 10, the who's seen Snoop Dogg and Drake perform live. That one, I was like absolutely stunned, but the CNAs knew. So that was also great. You know, they are the most connected to the residents if you can have some consistent staff. This was basically some of our outcomes that if people want to look through, we presented just a poster at the AMDA, which is the American Medical Director Association down in Florida in March. There certainly was interest within like some insurance companies wondering about, you know, there are some places that are, you know, exploring this, but it hasn't finding the way to find some funds to support this. You know, we had tried originally having our volunteers not only do the interview, but write the story. The bar for that is quite high as far as the amount of time it takes to actually do these life stories to this degree. But it is certainly a very rewarding opportunity for volunteers and easy to get engagement there, because really they will come, they'll have a wonderful connection with somebody. And then when they come to do another interview later, they'll visit anyone they've interviewed before because they already feel like they have a relationship with somebody. Let's see. Oh yeah. So this is some of our survey outcomes, which I don't know that there's too many things that you get like people saying 100% they liked something. So this was pretty remarkable because I think you have 100% of family members that are feeling that it's either agree or strongly agree that this has improved their relationship with the facility, as well as with the staff. And, you know, these quotes, you know, one of the quotes that I remember was actually one of the residents, part of his story was giving kudos to the staff. And he actually said, he's like, it's important for me to sing the praises of the staff so other families know how great the staff is here and feel more comfortable about their family member being here. This is just for our staff. And again, their sense that they feel like they have a more ability to understand the unique wishes of their residents they're caring for. So that was wonderful to get this feedback from our traveler staff that they, you know, really felt like this was helpful because it, again, gives them this toehold as they're constantly in new places, meeting new people. They certainly mentioned that this is not something they've experienced other places, and it really made it easier for them to have some ability to start connections and connect with people. And same thing for our residents, the, you know, feedback from them. And I thought this was, you know, kind of a remarkable thing. I think it speaks to the quality of the writing, in my opinion, but, you know, they would sometimes have little things that they, you know, their mother's name was spelled differently, or occasionally there'd be something they'd say that they wish they had talked about a little bit more, and that could be added. They could modify the story, but in general, the kind of changes that people wanted were pretty minimal, because I think they felt it really was very reflective of what they wanted expressed. And I think that is, you know, again, just really a challenging thing to capture in a way that's transmittable. I think that's the challenge of figuring out how do we, because each person is getting a piece of people's stories, but we don't have a place where we can put it together and transmit it. So I did love this resident's quote from her experience of that. For her, even just seeing that story changed her own sense of like, almost like wake you up out of a fog, because you can come to a place we are not, you know, at this facility, a small house model. It is a very institutional, long hallways, not home-like at all, honestly. I mean, we really have to like have the humans fill in the gaps for the plan of the building. And I think the building kind of makes you feel very institutionalized. And if the humans can, you know, be a shift away from that. So even just your own perspective, when somebody reaches back into your other chapters and brings them forward, you can honestly see that light, turn on for people when you're having this experience connecting with them, where they're like, almost like, whoa, I kind of hadn't gone in that chapter for a while in my own memory. This is just a sort of other places. How is this being funded through MemoryWell? Some places are using patient experience funds or getting grants, and it sounds like there's some carve outs within hospice in some areas, but these are, I guess, questions I would love people's perspective on, because I think that is a challenge. Like, we certainly figured out how to do it. We got a lot of engagement. It was really positive. We have completed our grant, and now there's people from, our sister facilities are like, oh, this would be great. We'd love to do it, but how do we do it? I think from a model that's sustainable financially. It's not an immense cost, honestly, but it is a cost. This one you can, read whenever. I don't want to take up too much time here, but I would say the sense for the staff sometimes, again, it's just like having more background to help them, be a comfort to the people they're caring for is really valuable to them. Okay. And yeah, I think I wanted to make sure that I didn't talk too long, because I could easily talk too long, to make sure that people had time to ask questions and have some ideas. And, from my perspective, what I would love to do is find a way to do like a phase 2 kind of thing, where you do this before anyone is starting long-term care, as the new people are coming in. Because again, I think that's where you're going to have the most impact. And a separate thing is, I personally hate redundancy, because I think it wears people out. So are there ways that the information that's captured in the story could then flow into, care plans and flow sheets a little bit seamlessly, so that when people are, you first come in, you're going to meet social work, MDS coordinator, nursing, dietary activities. If they have some of the things that they need to know about you, if they already know some of them, it'll feel good for both parties, and it also will make your work a little bit less redundant. So, all right. I hope I wasn't talking way too fast.
No, that was great. You know what? There's a couple questions in the chat from Maureen. Maureen, do you want to ask your question? Have you tried AI such as ChatGPT to write the stories?
So we haven't tried that yet. I think it wouldn't be impossible. I could probably take the recording of one and, stick it in there and see what happens. I mean, I've thought about that, and you know what I mean? I think it seems like a very reasonable thing to be tinkering with. We have new technology, and what can we make it do for us that would be helpful?
Yep.
I like that idea. So I haven't, but I've been thinking about it.
Another question, have you quantified any savings from reduced staff turnover?
That's a good idea. I think that's a hard one for me to imagine how you would actually peel out so many other variables, right? Like the traveler market was really, really financially huge. It's leveling down, so it's there's a lot of variables. I will say anecdotally, there was a time where we had no VON, no nurse managers, no unit coordinators, and no charge nurses. And actually all of those positions are filled. Whether that has anything to do with this, I have no way to really know, but I will say when people feel invested and connected, in that gains momentum. When people feel kind of, I don't know, like there's just unfillable amounts of to-dos without any joys, that doesn't make people want to join your team.
Deirdre, what, if you're willing to share, I mean, what was the cost of the 40 stories, just to give us a sense, I mean, it seems like this has a lot of promise as part of a larger grant-making effort that, we might do in partnership with private foundations or something like that.
So we the per story cost when the volunteer did the interview was $125. So there was some part of this grant, I think we had 45 stories, and I think the grant was maybe $8,000. But
Uh-huh.
the grant was like developing the, HIPAA waivers and, having some of the
Okay,
process, but the actual per story cost, I think, was 125 if we did the story. If they did the story, their like market cost is 279. From a legal perspective, something I've discovered is that you would need to call the story like story plus processing fee, right? Because in order for it to not be a Stark's Law problem, to look like an inducement, like this was a pilot, so it doesn't tick those boxes, but it needs to be less than $79. So just for pricing, like you would theoretically, this is the little bit that I know, but maybe make it be like the story is $75, but there's some kind of fee that's some processing fee, you know what I mean? I don't.
right. And obviously, the facility has to be willing to really embrace this, because I'm sure there's just a lot. I'm sure you had to do a lot of process and change within the organization, and so it's getting the stories done is one thing. Actually, putting them to use is another, I'm sure.
Yeah, and that's where I think, just like you were, having a moment with my brain here, Angie was mentioning, I think there's so much redundancy of work. So I would say that it's something that if you're taking some of those elements and using them to not have to do something twice and, begin to sketch out some parts of your care plan, I think it can offer a lot. And if you use it to its fullest, it's saving you time somewhere else. It's not an extra, it's a shift.
And let me just say for folks, the 8-minute BBC video, it was the most inspiring 8 minutes I've spent recently. So I highly recommend it if you haven't taken a look. I think what was inspiring for me is how the residents were so able to express in this video what it meant to them,
And I think one thing that was interesting to me going through that is the interviewer had, come over and we, talked about the program a little bit, but then he sort of got the experience where he followed our, volunteer, watched obviously and filmed them have their conversation. And then at the end of that conversation, they came down and it was the, the film guy and the interviewer and the volunteer. And the same thing that happens every time is they were like, oh my gosh, Dot is the most amazing person. They were just totally floored by, they couldn't have expected that this person had all these other chapters, because you're just seeing them now. And that is the same experience that every person that has one of these. So that would be my preference, is if the CNAs could actually do it for our purposes, because of concerns about HIPAA. They really restricted this to have it be a volunteer role partially. But I do think for relationship building, the optimal person to actually sit and have this conversation would really be the direct care staff.
Angie?
Yes, I just wanted to, Deidre, tell you about a program that we have at the Cedars with the honors students from USM. We have a 3-credit college course that we do at the Cedars called Story as Medicine. And I can connect you with the teacher, the instructor. And basically what she does is she goes through with these college students, composition, narrative writing, and we pair the students with our residents, and they come in and they actually develop this relationship with the residents, and they write these stories, and then I do pay for the book. They write an anthology, and then it culminates at the end with this whole thing with the family and the residents and the students, and they read their writings, and that's a great way. And I don't pay anything.
It's awesome
for them to do this. So you might look at USM, or not USM. You might look at the University of Augusta. I think the main college system, and maybe you can get students to come in and help support that program.
That would be awesome. Yeah.
Okay, that was wonderful. Dr. Hersink, that was really, really, really wonderful. Thank you so much for sharing.
Thank
Really
you
appreciate
for
it.
inviting me.
Yeah. All right. I think we're right on schedule here. That's great. So next up is Mary Lou Chiappi, who's a senior program manager at the University of Maine Center on Aging. She's presented for us before, and today we're going to talk a little more about that goal 1 and under the Moving Forward Coalition. And yeah, take it away. Need your slides up, or are we driving?
No, I'm driving. Thanks, Lauren. And hi, everybody. I just want to say, Angie and Deirdre, thank you so much for those presentations. I think these are the kinds of programs that get us a little closer to our goal of, more ideal person-centered planning. So thank you for that. Before I share my screen, I have a disclaimer and a request. The disclaimer is that the action plan work that we're doing right now in the Moving Forward Coalition is very much under development. It's iterative, it's evolving, it's very aspirational, and the bar is set high, understandably. So all I'm going to give you is a status report. There are still so many questions, and I'm happy to take questions and answer them if I can, but also bring questions back to the other folks. The update really is just kind of a point in time. And that leads to my request of all of you, and that is that my colleagues and I are across some goal committees are putting together a presentation for the Gerontological Society of America, the GSA conference in November. So I've put together this little slide deck that might inform that presentation. So I would love your feedback either today or just email me if it makes sense, what doesn't make sense, and if it doesn't make sense, I'll just start over. But I would appreciate your comments about it. Okay.
It may be good, Mary Lou, also to just remind people what the Moving Forward Coalition is.
Yes.
Or maybe
absolutely.
that's in your slides. I'm sorry.
Yeah, no, that's quite all right. Well, I will say thank you, Lauren, for the tee up about the NASEM report. And some of you who were at the June meeting where I presented might remember that the Moving Forward Coalition, which is the national group that's trying to implement the goals and recommendations of that NASEM report, is divided into 7 goal committees, and you can see them here. So over the last few months, goal committees 1 that I'm a member of, and then 6 and 7 have been working together and have created a combined action plan that is in fact focused on improved care planning. So if that helps with a little bit of context. Now that the combined action plan on person-centered care improvement, or person-centered planning improvement, is on the Moving Forward Coalition website, along with the video of the, I think, the July meeting where we unveiled this to the public. So I urge you to go and look at that combined action plan. It's very helpful. It has as the action plan goal this statement, and I just took it from the action plan. So the combined action plan for these 3 committees is to develop or adapt a data-supported, tech-enabled process for collecting resident goals, preferences, and priorities. That's what GPP is. Documenting them in a person-centered care plan, measuring the degree to which the care provided actually does reflect the residents' needs and wishes. So that's super straightforward. Like, why can't we do that? It belies like the complexity of really getting this done in daily life. And I put it in the chat, Angie, before. I so appreciate your candor about the difficulties that, despite the best intentions of the Cedars, and I often think, like, if the Cedars can't get it right, how's anybody else going to do it? But I appreciate your candor, how difficult it is to, for instance, involve direct care staff and to translate a static care plan into something that is accessible and usable every single day. The reason everyone's doing, or the reason the Moving Forward Coalition is doing this care planning improvement, is because we know there are deficits in our care planning. And sometimes it's structural deficits, sometimes it's processes or outcomes. I've experienced myself as a former res care administrator. I hear it from so many people. Care planning is not ideal. We're doing it. Of course, we're doing it because we have to do it, but we recognize the limits. The time, the place, the staff. That takes a long time, Deirdre, to do those interviews, right? We have to rely on volunteers. How wonderful if we could do more of that in-house. And all of those things are really getting in the way of what many of us have identified as a root cause of care planning challenges. And that is our ability to have and document a more expansive, I would say, care planning conversation that go beyond just clinical needs and preferences. You know, our goal in the Goal 1 committee is, okay, we want care planning to be inclusive, feel safe, empowering for residents and families, so people feel free to express their expectations and their frustrations and honestly, whatever else is on their mind, right? So the next couple of slides are using very basic kindergarten-y shapes, but it actually did help me think through why this is so hard. If you think about care planning conversations, and I mean both formal, structured care planning conversations in a formal care plan meeting, but also the informal conversations. Like, we know so much of what we hear, what direct care staff often hear from residents, is in the bathroom or in the dining room or in the hallway or the activity room, right? But when those conversations happen, we learn so much about the resident, in addition to perhaps the life stories that we may have heard in a more structured way. It's very difficult to put all of those sort of shape-shifting, free-flowing, cloud-like conversations into this box. And whether this box is a checklist or a form or an electronic thing, it only can contain so much, even if it has narrative space, right? Like, we've typed stuff in there, but we can't get it all. We are getting good stuff. Obviously, we're getting important care planning features, especially those clinical features. They are in care plans. But as Angie, as you noted, the requests are not always consistently implemented, consistently followed up in ways that residents really want. And what if a resident changes her mind on day 2? Where does that go? How can we have this sort of constant feedback loop? All right, so it's a square peg into the round hole kind of thing. So how can this combined moving forward action plan get us any closer to something ideal? Well, what we are looking for truly is that tech-enabled process for collecting, documenting, measuring, implementing all the wishes. We need a bigger box. It needs to be more flexible. I don't know. We're still defining what that bigger box is, and maybe it shouldn't be a box, but anyway, that bigger collection mechanism, so that we can get more of hear more about what residents want and give them what they want every day. It's helpful, at least it was for me, to divide up these care planning quality improvement efforts across these categories. So conversation, right? We know we need to have more conversation, deeper conversations, more expansive conversations. We know we need to document them. We know we need to implement them. We know we need to measure, evaluate, and the hardest part of all is this ongoing feedback loop. So some of the things that the action plan, the combined action plan, is doing in each of these categories is this. So we are, and you may remember from the June meeting, we are working on a guide, a care planning improvement guide that will be available, still working out the platform and the content and all those things, but will be available to long-term care communities. It will have orientation materials, because residents tell us, and families too, they don't know what to expect at a care conference. They don't have a consistent way of saying, well, I only want to talk to one person. I don't want to walk into a room of 10 and talk about my bathing practices. So we need to set some expectations. It will have a resource repository of things like the 4Ms and MemoryWell. What's happening out there that communities might want to choose from to make some quality improvement efforts. It will have foundational trainings on things that we know are missing, things like dignity of risk, ageism, personhood, self-determination. We are our life stories. We are way more than our life stories. We are our values and our beliefs. We're all sorts of cloud-like things that spill out over beyond a life story, as important as a life story is. In the documentation category, we are actively looking for, we may have to update it and or create it from whole cloth, is an improved care planning assessment tool that is, as I said, more comprehensive, allows a capturing of more free-flowing conversations, but also can be housed in an electronic platform. So it has the ability to be accessible by all, or at least, have a way for us to designate who can have access, because as we've heard this today, direct care workers do need to have access. On the implementation side, Goal Committee 6 is actively working on a concordance or an alignment measure. And that's their work. We know we need a reliable measure to tell us whether residents are actually getting the care that they want. And you can see here at the bottom, this work also requires some process changes, some process improvements, so that direct care workers can be included, and not only in the care planning, but in the feedback and having access to that information. In the measuring and the evaluating category, Angie, I think you said it, we do need communities need support tracking. What are we tracking from a care plan? What do we need to measure so that there's some internal and external accountability? And the goal, it's long-term and maybe too aspirational, but the hope is that eventually there will be a quality measure that takes into account some of the non-clinical but very important aspects of long-term care life. And then this feedback, I just stuck in here, innovation needed. This is the most difficult part. It needs a structural innovation. It needs some process innovations. Everyone is willing to hear and listen to ideas that anyone has about how best to make that feedback happen in a consistent way. So let me give you some specifics. That action plan has some milestones in it, and you can take a look at it. There's so many tasks, so much work happening simultaneously, even across these 3 goal committees. It's hard to keep track of it. And I haven't been able to keep track except for the things that I'm personally involved in, but I can give you a high level view. So we are, in the conversation side, we are working on some lay definitions. In fact, Barb, I'm sending you this afternoon, it's on my to-do list today, to send you the latest version of the proposed lay definitions. So you can take it up with your resident focus groups. We know that the words goal and preferences and priorities, those words do not mean anything to residents. We need a different lexicon. We need to talk about it in a different way. So that's part of the work that I and a small group are doing. We've gone back to the literature, the scientific literature, and where those words came from and what they mean, how they've been studied, and tried to incorporate those into lay definitions that will be conversation starters. That work is ongoing. In the second category, my colleague Tanya Roberts at the University of Wisconsin and her graduate students are, like, literally as we speak, combing through the scientific literature on assessment tools. And these are tools that have been studied and are in published papers. So therefore, the first net they cast returned 3,000 papers. So they're using an artificial intelligence literature search platform to help them sift through all of that. And as of the other day anyway, they had about 150 papers that will likely have assessment tools that could inform work that we need to do in this area. So the graduate students are actually going to read, like start to finish, those 150 papers and make some decisions about a final list of tools that we can all take a look at and figure out how we can use them. It's fascinating and very complex work, but so important, right? In the implementation side, Committee 6 is working with a nursing home improvement group in Michigan, and they have launched, I think they have already launched it, a small pilot of a provider survey. And that's really to help find out things like, okay, how are direct care staff being involved in care planning? Is anyone doing it at all? Or if they are, how successful is it? How are they tracking care plan implementation? How are they doing feedback? Whether and how are they doing it, both formal and informal? So we're hoping that some of the feedback we get from Michigan will help inform some next steps that we have to take. In the measure and evaluating category, again, super fascinating. It's big brain stuff, beyond my comprehension even, but Goal Committee 7 is analyzing a large data set from AdVault, and AdVault is a repository for advanced directive information. I think there's 10,000 10,000 people who have put their advanced directive wishes in there. So the smart people in Goal Committee 7 are analyzing, also using AI, analyzing those data and finding the questions, the themes primarily, but then the associated questions that will inform things like what matters to you. And the goal here, of course, is to take the AdVault data and what it tells us about things that matter to people, take those assessment tools from the literature, sort of map this out. Sounds a little magic-y, but I believe that we can do it, and then find the gaps. What's missing in structure, in process, in tech adaptation. And that's the work of the next 10 months, basically. This last category is blank because we still need some ideas there. And the reason I just want to show you it is so hard is because that feedback goes across all of these categories, right? It is a continual loop because Mrs. Jones will tell us in the bathroom on day 2 what kind of powder she does and doesn't like. Where does that go? Like, this is continual work. All right, that's kind of a snapshot. I want to leave you with one final point, and that came up in this concept came up in a conversation with colleagues the other day, and that is that it's when you think about the work that we're doing in terms of improving care planning, we're having conversations and documenting and implementing primarily for the benefit of residents, right? I mean, it benefits the larger group, but we are at the service of the residents who live in our communities. That's all great. There's a lot of overlap there, but we are also measuring and evaluating, some for internal accountability, but primarily for regulators and accountability to the public. So that has gotten our wheels turning about, okay, maybe we need to have either two separate or maybe overlapping processes, structures, definitions. Not really sure how this is going to play out, but we all agreed that the whole idea that doing things for residents and doing things for accountability to regulators and the public are related but separate. I'm going to leave you with that to ponder. And I'm happy to take any questions, feedback, comments.
Sounds like an awful lot of work. So hard.
It's super complex, and I say that knowing that I'm talking to folks who are so passionate, and I am too, about making progress. It is a long game, and we're just going to keep at it.
Can I ask maybe this is a silly question, but I've heard many times about the use of data from AdVault, the repository for advanced directive information. How much does that, I mean, there's more to person-centered planning besides an advanced directive, right?
Right. And I think, oh, sorry, was somebody else going to say something?
No.
Yeah, I think that's an excellent point, Lauren, and that's why this mapping has to happen. And again, we're not sure how that mapping will happen, but the Committee 7 folks have a long list of questions that have come out of that. And then Tanya's group will have a list of self-assessment tools. So where do they meet? I got thinking, Deirdre, after listening to you, that maybe some of the MemoryWell data could be used to inform the work that we're doing. And I've made a note to myself to check in with Alice Bonner to see if she wants to get in touch with the MemoryWell folks to see if they're willing to cooperate. I don't know how big MemoryWell is, but they're sitting on a lot of data, obviously.
I think they would be open. They have been extremely wonderful partners. The origin story for this really was the founder was a writer for the Times, and her father was in a community with Alzheimer's, and recognizing that all of the forms she got wasn't really translating into people knowing him better. So she wrote his story, and then the other families were like, "Oh, would you do one for mine?" And so it's a very personal, very, they've been extremely willing, cooperative, flexible partners.
Thank you for that.
Like a profit company, it's a mission company.
Yeah, good. It's good.
Anything else? Any other comments?
I see Heidi's hand is up.
Yeah, no, I mean, it's such inspiring work. And it's still, though, to me, it always comes down to the human beings having the time to process, see, use the information. And I do wonder if we need to, I'm going to bring technology back into it, and not that I'm a tech person, but like, wouldn't it be cool if the CNA, who's a traveler, doesn't usually work on this unit, is walking into a room and on their phone or whatever pops up, Mrs. Jones, these are the three bullets that are really important, and this is the care she needs during this time period that hasn't been offered. And so that it's like pops up right in your face. It's not this going to a paper over here, then trying to remember which room they're in. It just seems like we have a lot of inefficiencies in this arena because we're not particularly tech savvy, and we worry about confidentiality and expense and things like that. And yet the human capital is such an important aspect that we're taking those interactions and making people spend so much time doing things that aren't really that valuable. It just seems like there's a real opportunity right now to kind of blow that up and do something. But I don't know that we're the right people in the room to do that. I don't know that I am, but it just like, you write a great story, but then does the CNA have time to read it? Do they have the literacy to read it? It's just like so many of those barriers. And how do we like go to the next level so that it just makes it easy for people to do the right things? Because I think people really do, but we tap them to do so much. And it's so hard.
You're preaching to the choir, Heidi. I couldn't agree with you more, and I probably can speak for everybody on this call that that's a goal. We have floated, many of us have floated the idea of working with industry, working with point-click care on a HIPAA protected app that would be available. We all have our phones attached to us all the time. There's got to be a way to make something like that work efficiently.
I think there is a section of that action plans with the Moving Forward Coalition that is IT based, because obviously the funding for this is going to be huge. And then, I think a lot of people, their EMRs are non-integrated with their other health systems. So again, can Epic be integrated into the entire community, not just sections of the community of where the care is provided? And I do know memory well, we didn't access this, but they also do have like very user intended for direct care worker pictures that will pop up. Again, it may not be time-based as smart as what you were mentioning, Heidi, although I love that, where you walk in the room and it's like, what does I need to do right now? Because I agree, no matter what we're doing it twice. We're doing it and then we're writing about what we did. It's maddening. It's putting people out of the workforce.
I'll just say I think your comments are very appropriate, and we need to use big data to learn algorithms that make sense. And of course, that bumps us headlong into this tension between the universal, what do all people want, and what does Mrs. Jones want, the unique. So that tension between universal and unique is everywhere in healthcare, but certainly in long-term care, where we're dealing with 360-degree environments and needs. We have to respect it, and we also have to use it and leverage it to our goals.
You know what, we're going to have to sort of cut the conversation off now. We put on the agenda, I wanted to have an opportunity to hear some thoughts from one of our experts in the room, Ruta Kadanoff, who has a wealth of experience. She presently works at the Maine Healthcare Access Foundation, but has a wealth of experience in quality of life and aging issues and long-term care. So what do you think, Ruta?
Thanks, Lauren. My head is swimming. I want to thank everybody for the amazing information you all shared and the wonderful work you're doing. I think it is really inspiring. And I think, I thought about at the outset what I wanted to say, and it's evolved as I've listened to each of you. So, the first thing that I do want to mention, though, that's interesting, Mary Lou, that you ended with the question of accountability and regulation and the external factor. And I thought about, we've been talking about this for a long time, right? And when you look back at OBRA 1987, 26 years ago, that calls on every nursing home to provide the care and services to support each resident to attain and maintain their highest practicable physical, mental, and psychosocial well-being. That's what this is all about, right? So we've said for a long time we want to do this. Why is it so hard? Well, you all enumerated all the reasons why it's so hard, right? There's the human factors, there's the organizational factors, there's the challenges of time and turnover and the imperfection of systems. And I think it's wonderful that there's so much focus on what tools can help to make this better. And you've highlighted some of those tools, and I applaud you for implementing them. The place I want to leave everybody with is sort of circling back to like, what's the grounding and the underpinning for it all. And Angie, on your very first slide, you had a quote that said, it's about living life my way, personhood, autonomy. I'll add home, like recognizing that this is the resident's home when we're talking about long-term care. And Deirdre, I was just so moved by your point, the quote from the resident about the depersonalization that happens in institutions and sharing their story, bringing them back to remembering who they are. I mean, I'm tearing up talking about that. So I think as leaders in this field, it's incumbent on us to figure out how we move from, how we integrate tools, but do it in this bigger context of why are we doing it? What are we doing it for? What's the underlying philosophy? And less about kind of the mechanics of it, which is there to support it. And I'm not saying this well, I'm not meaning to minimize that in any way, shape, or form. But to me, the biggest challenge that we face today, and at the same time, maybe a part of what this is a solution for, is the staffing crisis, the lack of consistency in staffing, the turnover, because at its heart, what we're talking about is strategies for people who don't know one another to respond to their needs, right? So if we can tackle the piece of how you create a system where people can know one another and build on that relationship to provide care in a resident directed, thank you, Maureen, way, it's the tool is still there and the tool is still important, but that's really the underpinning, is that relationship. And I think what we heard too is that there is an outcome that's about helping to retain that quality staff that Angie mentioned in the Sam L. Cohen households, and we've seen it in other household models in the greenhouse model. So I would just encourage all of us to think about both how we do this, but also, why and what the leadership component of this is, and how tackling the staffing issues is just as important as creating the tools to help people pretend they know people. I don't mean that in a condescending way, but that's essentially what we're saying. I don't know you, so I need this tool that tells me what matters to you. That's a good stopgap. But in the end, what I really want is to be cared for by somebody.
It's wonderful. Wonderful. So I just want to, there's a couple of comments in the chat. I just want to let you know that we will go through those and get answers to your questions as part of our follow-up notes. And with that, Paul, do you have any closing comments for us here?
Just to thank our panelists and all of you again today. This has been another great meeting. We look forward to seeing you again next month. Thanks, everybody.
Thank you, everybody. Thank you so much.